Well, I have the hard task to speak after Professor Gianesini and explain the same things, but I'm trying to do explain the reasons why we choose Chiva instead of other procedures. We've been talking the whole day about killing the sapheous vein, but now I'm talking about how can we spare and why we consider the sapheous vein should be spared. The Chiva strategy basically aims to lower the transmural pressure in the leg, and we all know that the transmural pressure is responsible for the symptoms and complications of venous disease. The first thing, the venous shunts, that the source of pressure should be closed, and the end of the pressure should be closed if you have a collateral. The sapheous veins and perforators should be spared. And if you leave a non-draining collateral, you will probably have thrombophlebitis. So you can't leave non-draining collaterals, but the draining collaterals should be left because they are important in the long term. So this is Chiva, lowering the transmural pressure with the least vein destruction possible. Chiva results versus stripping. I will do a little more thorough evaluation of this topic because the prior evaluation was a bit summary. So Chiva has a few randomized clinical trials. They have been reviewed by the Cochrane Review 2013 and 15. And what does Chiva have compared to stripping? 5-year and 10-year recurrency is less in Chiva than stripping. Chiva has less bruises than stripping. Has no nerve damage because it's made under total local anesthesia, and the patient warns you when you touch a nerve and you can't cut it. It's difficult to cut it. It's highly operator dependent, and in some studies there is more superficial phlebitis than in other methods, but we will talk about this later. I here have the results of this meta-analysis. So in the first part of the left part of the picture, we have the results concerning recurrence. We have 3 clinical trials showing less recurrence than stripping, and in the second part we have less bruises and less nerve damage significantly compared to stripping. Limb infection was pretty similar, and superficial phlebitis didn't have statistical difference because the second biggest study didn't have a lot of phlebitis. There is one clinical trial with more phlebitis than in the other. I'm talking about how societies and other people see the technique. The first part is the result of the American Venous Forum. Peter Glovitsky is the responsible for that. And the consideration is that they suggest the sapheous vein, the Chiva can be used and selectively only in centers that do properly Chiva, that are used how to do it. Professor Davis also has reviews on the topic and considers that is another technique that can be done. I'm talking a little about nerve damage now. I'm only taking randomized clinical trials. I'm not taking reviews or other data. So stripping in the clinical trials I found had 7.4% of nerve damage, radio frequency 5.2, endolaser 3.8, actually a bit less than the results had been shown this morning today here, 4.6%. And Chiva had no nerve damage because it's made under local anesthesia and the patient avoids the nerve damage. It's actually important today because, for example, in England they had a study on malpractice sues in vascular surgery. The main chance of the patient to gain a claim in malpractice is nerve damage in England. And the damage, the values are sometimes large. The learning curve in Chiva is a problem because the superficial phlebitis happens a lot if you leave some vein undrained. You can't leave a vein undrained because it will get clots. I have here a study made like 30 years ago in Italy, a multi-center study of Chiva, 5 centers doing it. They had 9% of thrombophlebitis in Chiva. Comparing to other techniques, for example, clinical trials about stripping had 3.3% of thrombophlebitis, and the laser 6.5%, foam 10%, and radio frequency 8.8%. So if you do Chiva in a center that is not properly trained to do that, you probably have worse results and almost the same amount of thrombophlebitis than foam. But for example, I take another study from a group that does a lot of Chiva from Spain. They had 1.3% of superficial thrombophlebitis, and all of these were diagnosed by duplex. No patient needed treatment of this phlebitis. In my experience in Brazil, we have 1.6% of thrombophlebitis, and only by duplex. I never had to treat thrombophlebitis of a patient yet. So 5 reasons I prefer Chiva. Use for bypass operations, evolution of venous disease, new escape points are easier to treat. You can treat post-thrombotic syndrome with Chiva, and the results long-term are proved by randomized clinical trials. I'm not talking a lot about bypass because we all know that the saphenous vein is important for bypass, but we don't know how many patients doing Chiva will need this vein in the future. But it's something that should be mentioned. The evolution of chronic venous disease, we have studies, biochemical and animal studies, that show that the less veins you destroy, the better. Actually, the surgical trauma and mechanical alterations are lessened, and this leads to less pressure and less chronic shear stress. And we all know that the pressure and the chronic shear stress are responsible for remodeling the veins. Oops, back. There is a study, actually Professor Gianesini is one of the authors, that shows that the less tributaries you do the ligation when you are doing a crossectomy or a crossotomy, the less recurrence you will have. So this shows that the clinical importance of the approach of minimal dissection and destruction of veins might be important. Treating new escape points. When you leave the saphenous vein and you have a new escape point, what's going on? The new escape point will almost always go to the saphenous vein. And if it doesn't create a great transmural pressure increase, you don't need even to treat this patient. Sometimes you need to treat it because the transmural pressure is highly increased. This is a case of a woman with saphenous insufficiency, and the vein has been destroyed. You choose the method. What will happen a few years later? That vein that was normal in the first operation will be left as a stump with pressure chronic in the same area. This vein the blood must flow. So what happens? This vein creates others until it gets to a place where it can go to the deep system. This creates a lot of recurrences. The recurrence after Chiva, as you leave the saphenous vein, you leave the highway to take the blood to the perforator and to the deep system. And this highway is deeper than the collaterals created in the recurrence of other techniques, and it usually can't be seen. So in this case, that is easy to treat. For example, only one shot of sclerotherapy or sometimes a ligation under local anesthesia. This case would be treated if the patient gets symptomatic. Another thing, life is long. Professor Gianesini just told that, but we may have a trauma or a deep vein thrombosis in the deep system, and the saphenous vein may work as a bypass, a natural bypass for this patient in the future. If the saphenous vein is not there, you lose this opportunity. Conclusions. The approach of excessive vein destruction might bring more veins in the future. Chiva is a great alternative to treat venous insufficiency. The cosmetic results of Chiva are not delta destruction for users. I had to learn the cosmetic results of Chiva. I have to learn to treat the collaterals. It's more important than treating the saphenous vein. And the books and the instruction for users only talk about what you should do with the sapheous vein. The final considerations are keep an open mind. We can use Chiva with the concepts of laser. There are studies of short burns in the hemodynamical places to solve the problem of the saphenous vein. I'm not just sure if it's worth to spend the laser money if you can get the same result with one tie knot. And be careful with Chiva as a second alternative because the results are really poor. Chiva should be really studied to do it. Okay, thank you.